For the update, I wanted to touch a little bit just on vaccines again, just because it's such a crucial topic, just to give you a little bit of data on just how effective they are, and review things a little bit, because that's changed a little bit as well. And just to kind of go back to the basics, what is the purpose of the vaccine? Why do we have vaccines? I think I put in A and B as a choice, but it is not to completely prevent all infections. All right. So that's the wrong answer. It really is to prevent serious illness and death. And, I always have a lot of questions, particularly in this latest surge with Omicron. There have obviously been a lot of breakthrough infections in folks that were vaccinated. And, some of my patients will say, or even staff that I work with, well, what's the point of a vaccine if everybody's getting infected? And as I'll show you in some slides coming up, the real reason is to prevent serious illness and death. And really, we have almost no vaccines that are sort of what we call 100% sterilizing and 100% effective. So, there are people who might rarely get hepatitis B, even though they've been vaccinated with hepatitis B and so forth. So vaccines aren't necessarily 100% at protecting you from infection. So if you look here, this is New York City data. This is as updated as they have through January 16th. And this is cases per 100,000 people in New York by vaccine status. And if you can see here, this is, in other words, people who test positive. So in the unvaccinated group, we had this huge surge getting up to over 14,000 per 100,000 people, which is really staggering in terms of how widely Omicron spread. But if you look down here at the vaccinated, it was fewer than 2,000, okay? And it peaked to 2,000 and is coming down. So the average citywide was really brought down by vaccinations. And that's hugely important, particularly to those of us in the hospitals, to not overburden the emergency rooms in the hospitals. And if you look at hospitalizations, same thing, but an even lower number. See, this is 200. We got up to over 600 hospitalizations per 100,000 people in the city. But if you look down here at the orange line, the vaccinated, it was a really, really small number per 100,000. And most importantly, in terms of deaths, a tiny number, okay? So this is 15 now on the y-axis. And we look down here at the vaccinated compared to the unvaccinated. And you see really a huge difference. So this is what vaccines are all about, and it really has made a very striking difference for the health of individuals in the city, and also for the burden on the hospitals. And you can see this is kind of a busy chart, but basically this is in New York, gray is Delta replacing Alpha, I guess, beforehand. And you get all the way to over to this side, and you see how very quickly Omicron took over to where it's now about 100% of what we're finding in the city. So quite dramatic changes over time in terms of the epidemiology of what strain of the virus we're seeing. This was an interesting thing that I just saw yesterday. It's a study that was done. And if you compared our vaccination rate to other places in Europe, and specifically in this case, Denmark, which has a higher rate of folks who've accepted the vaccine, you would see that this blue down here at the bottom is the hospitalizations that we would have had if we had that high of a vaccination rate. And this red are what we call the excess hospitalizations. So all these people, at the peak, 50,000 difference here. And the same thing in this latest peak with Omicron. So many, many more hospitalizations that could have been avoided if we can just incrementally vaccinate more folks. So it's still super important to get the message out and encourage people to ask questions and have their concerns addressed about the vaccines. This is just another slide with a similar story, but also now talking about the having had 2 vaccines, or 1 in the case of J&J, versus having been boosted. And you can see that, again, per 100,000 population, as we moved into Omicron here on the right, but even through the Delta wave, if you're boosted, you are far less likely to be infected and to have a positive test and have symptoms and get sick than if you just had the primary series. So it is definitely the case that a booster is super helpful in terms of protection, particularly against Omicron, but even the previous strains. This is just, again, another way, but just to highlight the numbers down here. If you were unvaccinated in November, 18 and older, you had a 13 times more likelihood of testing positive for COVID, and 68 times higher risk of dying from COVID. And you see these numbers down over here are just really impressive in terms of the unvaccinated, in terms of deaths by vaccination status at booster dose. You see that deaths in the boosted group is really 0.1 per 100,000, which is, we'd like it to be 0, but that's very, very good. Compared to fully vaccinated, it's 0.71, and unvaccinated is all the way up near 10 per 100,000. So again, really highlighting the importance of both vaccination and the booster dose. This I just wanted to introduce because it may come up more in the days and weeks coming up. There's the Omicron from the beginning actually was a family of viruses that are slightly different from each other. The variant that we're dealing with now is called BA1, but there's a BA2 and a BA3. And the BA2 actually, this is in South Africa, which was hit with Omicron the earliest. The BA2 variant is now sort of outcompeting the BA1 variant. In green here is BA1. This is the BA2 variant. Down here is the BA1.1, and BA3 is down here. So these are all in the Omicron family. It looks like the BA2 variant, which has now been found in over half the states in the United States, is even more transmissible than the Omicron BA1, but it seems very likely that there's cross protection. And at this point, since Omicron really went like wildfire through the community, not only with breakthrough infections, but really a lot of infections in the unvaccinated that we're hopeful, although we don't know 100% for sure, that even though it is more transmissible, we're not going to have a second surge, knock on wood. But the next week or two, they'll have a lot more information. It certainly does not seem to be any more serious than Omicron. One of the things that's very clear about Omicron is that it is much more likely to infect the upper respiratory tract, meaning nose, sinuses. It is not as good at attaching in the lung, and that's a very good thing. And that's why Omicron tended to be overall milder than Delta by quite a bit, since it doesn't seem to get into the lower respiratory tract, meaning the lungs, as well as Delta did. So that's good news. And right now, I don't think anyone is overly concerned about this sort of second variant of the variant as of yet, but it is out there. Also wanted to go back to the basics and kind of update on quarantine and isolation. Quarantine is the term that we use if you've been exposed to someone with COVID-19 versus isolation, which is what you do if you have COVID-19. There's a lot of information on this, and this is all on the CDC website, but the big update was that the CDC has recommended that for an exposure, you can stay home for 5 days, with day 1 being the day after the exposure. You know, even if you don't get symptoms, it would be reasonable to test 5 days after you had contact with someone with COVID-19. But even after those 5 days, it's recommended to be, you know, pretty careful, continue to mask, which we should all be doing anyway. And if you do develop symptoms, to isolate. You know, we're erring on the cautious side when we talk to folks who've had serious exposures. But I think it's reasonable, you know, particularly if you don't have any symptoms, if you get tested on day 5 with a rapid or a PCR and you're negative, then I think you can say you're out of the woods. And that's in folks who have not been vaccinated. If you're vaccinated and exposed, the CDC says you don't have to quarantine unless you develop symptoms. So another great benefit to vaccination, given that you know, it offers such good protection. But if you do have symptoms, of course, you should undertake the quarantine and get tested at 5 days. And continue to wear a mask after those 5 days for another 10 days. If you have had COVID in the past 90 days, you don't necessarily need to quarantine, but again, be careful for that 10-day period. In terms of isolation, which would be if you test positive for COVID, day 1 is the first full day after you develop symptoms or you had a positive test. You should, regardless of your vaccination status, stay home for at least 5 days. Try to avoid others. If you have to have folks in your home, try to separate from them and wear a well-fitting mask if you're exposed. If you have no symptoms for 24 hours and no fever without using any medications, you can end your isolation after that period and continue to wear a mask. But if you continue to have symptoms, you should isolate for another 5 days. It's not recommended for the vast majority of people to get a test at the end of 10 days. Particularly the PCR can remain positive, as you recall, for quite a while, even after you're not really contagious. So as long as you're asymptomatic and it's been 10 days. In folks who are very immunocompromised, that could be a little bit different. That would be people, transplant patients, or untreated HIV with very low T cells, cancer chemotherapy. Folks like that may need to be a little bit more careful. And in those patients, we may retest. The vaccine schedule, just again, go over that briefly. You know, Pfizer is still 21 days after the first dose, so although certainly you can do it, you know, later than that. Moderna is 28 days after the first dose. For anyone who's immunocompromised, cancer, transplant, et cetera, they should receive a 3rd dose. That's not really considered a booster. It's just a 3rd dose in the series, at least 28 days after their 2nd dose. So for those folks, your initial series really should be 3 full doses. And then the boosters are now recommended 5 months after the 2nd dose, or in the case of immunocompromised, the 3rd dose. And you can mix and match for the booster. You can do a Pfizer if you had Moderna, or a Moderna if you had Pfizer. For anyone who got a J&J, you should use one of the mRNA vaccines, Pfizer or Moderna. But and that's 2 months after the first dose. So that's sort of the vaccine schedule as it stands right now. And we don't, you know, they've been looking at studies, particularly in Israel, doing a 4th dose, or, you know, 2nd booster, as it were. It seems to give some benefit, but it's you know, pretty marginal at this point, and not something we're necessarily recommending here yet. Back to the basics. How can we prevent COVID? vaccines and boosters, of course, masks, and N95s are probably the best. KN95 and 94 is fine. Surgical masks are excellent, or even a double surgical mask, or say a cloth mask with surgical over it, or cloth, but anything is going to give you an edge. And again, just reminding folks that if you're with people, it's a little chilly these days, but ventilation really has a big impact on, exposures in indoor spaces. So even just opening a window and getting a little breeze can be super helpful. One thing I'll talk about a little bit later, I have a slide. There's a mixture of monoclonal antibodies that goes by the brand name Evusheld, but that is an intravenous infusion that is for pre-exposure prophylaxis. And when would we use that? We'll talk a little more later, but that could be in people that have been vaccinated. It shouldn't be a substitute for vaccination. We want to encourage everyone to get vaccinated, but it could be for someone in whom we are concerned that they're not going to mount a very good response to the vaccine. And again, getting back to those folks that might be more immunocompromised in the transplant and chemotherapy population, where even sometimes with third shots, they may not be getting as much protection as we'd hope for. And this intravenous infusion seems to give people, up to 6 months of protection in the order of about 80 or 90% reduced risk. So that can be an important tool. It's very limited in terms of the supply, like a lot of these things are right now. But this is sort of the prevention, distancing, of course. But these are the really main pillars of prevention right now. There's some new options now. And again, in part due to the limited supply of all of these things, they're definitely being limited to people who are not hospitalized, this group of treatments. So it's people with sort of mild to moderate disease, but who have some sort of risk factor. So it's not something right now that's available to everyone who tests positive, nor is it really necessary for everyone. As we've seen with Omicron, most folks do just fine, particularly if vaccinated with mild disease. But in someone who is older, or someone who has other risk factors for more serious disease, other illnesses like diabetes or cancer or heart disease, these would potentially be options. And you want to do it the sooner the better. Each one of these things sort of has, different limit in terms of how many days after infection it's available. But just as with, for instance, treating folks with flu, the sooner you start, the better. So one barrier is, getting folks tested. So, if you have had an exposure, or you do feel like you have symptoms, and you do feel that, you may be at risk, you haven't gotten your booster yet, or you have other illnesses, go ahead and get tested. The supply of these is picking up a little bit, but the first group of treatments are the monoclonal antibody infusions, B and C, bamlanivimab and etesevimab, casirivimab plus imdivimab. Those two have been around for quite a while, but they're not effective against Omicron. So right now, they are not being distributed. They were effective against Delta. Again, if you were able to give this to someone within 5 to 10 days of their infection with mild to moderate disease, not hospitalized, you reduce their risk of hospitalization by 80 to 90%. So pretty dramatic in terms of preventing more serious disease once someone has an infection. Sotrovimab is the monoclonal that is effective against Omicron. Again, it's been hard to get, but hopefully as cases right now go down, which they are, it'll be more available for the folks that need it. Logistically, it's a little challenging. There are infusion centers around the city, and most hospitals can set it up, but it means getting tested. It means arranging to get it and going to get the IV infusion. Even more complicated still, but also very effective, remdesivir, which we have been using since the early days of the pandemic. It was one of the first drugs that was approved, is used for treatment in hospitalized patients, but a very nice study showed that giving it for 3 days, again, in that mild to moderately sick group that's not in the hospital, also reduced the chance of hospitalization quite a bit. That's even more logistically challenging to try to give someone an IV drug for 3 days. They're working on other formulations, either oral or injectable, such as intramuscular. So that may be something that we will have more availability later. And then the newest kids on the block are the oral medications that were approved pretty recently. Again, the same supply issues, although molnupiravir, the second one, is a little more available than the Paxlovid. But these oral medications, again, and I'll talk a little bit more about them in the next slides. Paxlovid, much more effective than molnupiravir by a long shot. Again, reducing the risk of hospitalization by up to 80 to 90%. Molnupiravir was pretty modest. And the study on which it got approved sort of had a very big benefit in the first half of the study, and then not much benefit at all in the group that was in the second half of the study. And so the average looked to be around 30% protective, but it wasn't clear why the results were so much better early on versus later. Potentially had to do with the circulating strain. It does seem to be active against Omicron to some extent, so it's a reasonable option. Just very, very briefly, in hospitalized patients, we will use remdesivir intravenously. Everyone who's sick enough to be hospitalized and be on oxygen will get steroids. And then there's a few other things that can be used, other kinds of infusions if folks are very sick. These are the two monoclonals that were available earlier, and they have very, very reduced susceptibility to Omicron, so they're not being used. That's the bottom line on those, but sotrovimab has no change and still works well against Omicron. So that's really the only one that's being offered right now. And again, this is the intravenous one-time infusion done as an outpatient. Here's Evusheld that I was talking about, is really PrEP for folks that are higher risk. It's for 12 years of age and older. They are not currently infected with COVID and have not had a known recent exposure to COVID. They have moderate to severe immunocompromise due to a medical condition, or they're on medications that suppress their immune system. And so the feeling is that they may not have a good response to COVID vaccination, or someone for whom the vaccination with any of the available vaccines is not recommended. For instance, allergic reactions, difficulties with the initial shot. This would definitely be an option as we get more of it. So that would also be a one-time infusion, kind of limited to this group. It's not authorized for treatment or for post-exposure prophylaxis. It's not a substitute for vaccination. We should still, encourage folks to get vaccinated. That is absolutely the best protection. You should wait a couple of weeks after vaccination before you administer it if you're going to. There's a list of folks who might qualify for that on those websites. So that's pre-exposure prophylaxis. It does seem to have some degree of reduction in susceptibility to Omicron. So It's still authorized currently. And, we'll have to see what develops, whether Delta makes a comeback or Omicron remains the dominant variant. But it's still authorized for use, even though it doesn't look to be as good at preventing Omicron. So again, vaccine and booster are the foundation on which to build rather than substitute. In terms of Paxlovid, they're tablets, and interestingly, nirmatrelvir is a protease inhibitor. Protease inhibitors we're very familiar with, having had the first ones came to market in 1995, 96 to treat HIV. They've been used to treat hepatitis C. So we have a lot of familiarity with protease inhibitors. Interestingly, it's combined with ritonavir, which again is a HIV drug that's been around since the 1990s, initially to treat HIV, but subsequently was found to be good at boosting the levels of other drugs that it's given with. It inhibits their breakdown in the liver. And so when you take a drug that may not be absorbed that well and get high levels along with the ritonavir, you get very good levels. The downside of that is that ritonavir has a lot of interactions with other medications, including medications for blood thinners, heart medications, all kinds of medications. So you really, need to have your doc go through very carefully with you the medications you're on. Unfortunately, it's only a 5-day course. So usually things can be adjusted. So this is for outpatient, mild to moderate disease, 12 years of age or older, who've tested positive and are at high risk for progression to severe. So not for everyone, but those at high risk. The drug-drug interactions I mentioned, you may need to reduce the dose in people who have kidney disease. For people who have severe kidney disease, it's not recommended. Ditto for liver disease. And there are some resistance concerns, although over a 5-day course, I wouldn't be too worried about that. Molnupiravir works by causing the virus to actually mutate, which if you hear that doesn't sound like a good thing, right? We're talking about all these mutations that are creating these various variants. But it's what it does is it essentially cripples the virus very quickly by causing so many mutations that it can't copy itself. There are some concerns about that. It has been authorized under emergency use. There also have been concerns raised that it could actually be mutagenic for our human cells. That has been looked at certainly in animal studies and some human studies, and it's felt to be safe. Again, it's a very short course with sort of the same indications as Paxlovid. So groups that are positive, mild to moderate disease, and at high risk. So that is an option, and it's more available. But remember, the benefit was more modest than the 80 to 90% reduction by Paxlovid. It's more in the 30% range. So it's not recommended because of the mutagenic effects during pregnancy. The folks that are of childbearing potential should use effective contraception during treatment and for at least 4 days after the last dose. Not recommended to breastfeed during treatment. So there's some cautionary notes here about it, and I think we're all hopeful that Paxlovid will become more available, despite the drug-drug interactions. It seems to be much more effective and fewer concerns. It's not to be used in folks less than 18 years of age because of bone and cartilage growth.
What is the sort of logic behind the time between the second shot and the booster? Why do you wait the 5? I know originally it was 6 months, now it's 5 months. Why is it that there's that wait time?
The idea is that you've given, with the 2-shot series, you've given your body time to not only develop neutralizing antibodies, but to develop more mature response in terms of T cells and a broader response in the parts of the immune system that we don't really measure or look at. And then so that sort of maturing, and then with the boost, you're really able to boost that whole broad array of response. So, I think it's along whether 5 months, 6 months. I think the 5 months was in part just, the urgency of wanting to get folks boosted prior to the Omicron surge.
So it's basically just like that's a kind of ideal time to sort of re-up your body's response.
Yeah, you're going to get a much more robust response if you sort of let things develop for a few months before you go in with the booster.
Do you recommend mixing and matching the booster? So if you got Moderna, should you get the Pfizer booster? Is there any sort of indication that that is better protection or more comprehensive or anything like that?
Yeah, there have been some studies, mostly not with clinical outcomes, where they're just sort of measuring antibody response, that potentially mixing and matching, particularly Moderna, in part because the Moderna vaccine is a higher dose. It's 100 micrograms. The booster is 50 micrograms. Pfizer, each shot is 30 micrograms. But we don't really know if those higher antibody levels translate into a huge benefit. So I think it is fine, but I would say that sometimes the devil is better if you did okay with the Pfizer, or even if you didn't do okay, but at least you made it through.
Yeah.
A lot of folks feel more comfortable just sticking with the one that they had. So I don't think there's enough compelling evidence to say that you should mix and match. It's fine to do, particularly availability wise. If you're somewhere and they're like, all we have is Moderna today and you want to get the booster, go ahead and go for it.
Yeah.
Even if you got Pfizer. People who got J&J to definitely choose a Pfizer or a Moderna.
I heard some news recently that they may be looking at the vaccine for younger children too.
I just heard that they're talking about trying to get it authorized as a 2-shot series in the 2 to 5-year-old group. The results were a little disappointing in a 2-shot series, and they're continuing to looking at it as a 3-shot series, but they may have enough data to say, hey, let's get started, and then we'll see if you need that 3rd shot.
Add a 3rd somewhere down the road.
But as of now, still, it's not approved for under 5. I think people are cautiously optimistic that we're going to enter a period where we're definitely not out of the epidemic phase. And we can't say that it's, endemic. But, potentially, over the next 12 months, we're going to get to a level where there are going to be cases, but we're going to have much more tools available. You get tested, you start on Paxlovid, and you're fine. So I think that's the goal.